All right, so this is your level 4 test 3 workshop. So you guys are going over trauma, triage, shock, DIC, ARDS. That's a lot of content, so I'm just going to be focusing on shock, DIC, ARDS, mainly the pathophysiology behind it. Dr. Schneider's requested that I focus more on patho, so that's what we're going to be focusing on. So starting in chapter 66 on page 1587, so shock is a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. You guys, have you had your lecture on this yet? So you know it can be caused by a variety of things. We focus in on a couple different types and we'll kind of hone in on each one, the patho behind it. Your book starts with cardiogenic shock. So coming fresh out of your cardiac test. Cardiogenic shock could be a result of systolic dysfunction, so the definition of a systolic dysfunction is problem with systole. What is systole? Contraction. Yeah, so you're pushing blood forward when the heart is contracting. So systolic dysfunction is the inability of the heart to pump blood forward, whether it's into the pulmonary system or into the aorta that goes to the rest of the body, the heart itself, and the head. Don't forget that the first branch off the aorta is that coronary circulation. If we have a left-sided problem, that impairs perfusion to the heart itself. So that comes into play with your pathophysiology of systolic dysfunction. If on the left side, the heart is not perfusing itself. So you're going to have a problem already with the pump that's going to be exacerbated because you can't get blood to the heart, to the pump, and so it just kind of snowballs from there. So an example of systolic dysfunction would be MI. You guys just studied that. Myocardial infarction. For the trauma purposes, blunt cardiac injury. Severe systemic or pulmonary hypertension. So if you have this, pretend this is the left ventricle, this little circle here, and this is the aorta coming off of it. So if we have severe systemic hypertension, that pressure inside the aorta is so high, what does that increase in terms of your cardiac output, the words we described? Afterload, thank you. So afterload is too high, and the ventricle itself isn't strong enough to pump against it. So then you have a problem with that pressure in the aorta and getting that blood out into a vessel that's entirely too pressurized. It's like if I tried to open a door and some big burly dude was standing on the other side trying to keep it shut. And that can be true of your pulmonary arteries as well. So if you have severe pulmonary hypertension, like in lung diseases like COPD, that could be a problem for your right ventricle, right? We could also have myocardial depression from metabolic problems, and we're going to talk about that in septic shock, because when our inflammatory system is overloaded, that actually causes myocardial depression. A lot of those inflammatory mediators, as well as if you're septic and you have a blood infection by a bacteria, they produce endotoxins that depress the myocardium. and make the pump less effective. We could also have diastolic dysfunction. So what is diastole? If systole is contraction, what's diastole? The filling, yeah. So your ventricle is having a hard time relaxing enough, or maybe it's hypertrophied to the point where you can't fit very much blood in there. There's a picture in your book, I think in the hypertension chapter, where you look at a ventricle that's normal versus a ventricle that's hypertrophied. And if you look at the normal ventricle vertically down into it, the muscle wall is relatively thick, but with hypertrophy you have a very, very small ventricle, like a small space in the ventricle to fill. So that's a problem with ventricular hypertrophy as well. We could have a problem with a pericardial tamponade. Have you guys studied that yet? So you have so much fluid in the pericardial space, which is that layer around the heart. Pretend this is your heart. This pericardial sac that should only have about 10 to 15 mils of fluid in it. But when we have so much fluid in it, it can actually obstruct the ventricle from filling. So it creates a smaller space to be filled, and therefore less stroke volume, right? Because we can't fill enough to eject it. I mentioned, whoops, I don't know what happened. Ventricular hypertrophy. Okay, coming back from your last test, it can also be caused by dysrhythmias. So ventricular fibrillation, ventricular tachycardia, you can develop cardiogenic shock from that, which basically, as Ms. B says, is like piss poor perfusion. So we have poor perfusion as a result of the pump. When we look at the different types of shock, you could have a problem with the pump itself. You could have a problem with the pipes, like in anaphylactic or in neurogenic shock. And you can have a problem with the prime, which is the blood. So that would be like your hypovolemic or your hemorrhagic shock. So understand your etiology behind it, and we'll kind of like integrate it all together once we've talked about each one. We could also have structural problems. So problems with the valves, like valvular stenosis, basically meaning you have like a smaller space for that blood to go through, and regurgitation, where the valves are not efficient at keeping back the backflow of blood, so it's moving backwards. Ventricular septal rupture, so the septum between the two ventricles, the right and left, ruptures, and you guys studied what happens in infants that have a ventricular septal defect last semester. You have mixing of oxygenated and deoxygenated blood, right? So that's a problem in terms of perfusing the body. So I'm going to go to the next slide. And remember, this is recorded, so if you want to go back, you can do that. We don't have a lot of time. So in terms of the pathophysiology, we have primary ventricular, that's what this means right here, primary ventricular ischemia, meaning decreased blood flow to the ventricles as a result of any of these, the etiology we just went over. We could have structural problems, like we talked about with valvular stenosis or regurgitation, and then also dysrhythmias. So any of these causes can lead to systolic dysfunction, which is your ineffective forward movement of blood. So you've got these contributing to your systolic dysfunction. What does that do to stroke volume? Does it increase stroke volume or decrease stroke volume? Decrease. Yeah, because we're not ejecting enough blood out of the heart. What is stroke volume? You guys just came out of this test. Did you dump? Did you dump it all? Yeah. So your stroke volume is the amount of blood ejected from the ventricle every minute, or with each beat, and that contributes to your cardiac output. So if I have a systolic dysfunction pumping that blood forward, that's going to decrease my stroke volume, which decreases my cardiac output, right? Because that's part of my formula. Cardiac output equals stroke volume times heart rate. So decreased cardiac output. We could also have diastolic dysfunction, which decreases stroke volume because I don't have enough relaxation to fill my ventricles. So I don't have anything to pump forward anyway, even if my ventricle did contract adequately. So diastolic dysfunction. If we have diastolic dysfunction, that blood has nowhere to go. So it's going to increase from the left side of the heart, increase pulmonary pressures, backing blood up from the left side, which leads to pulmonary edema. Now, pulmonary edema, and we're going to talk about the VQ problems, but if we already have a problem with the pump getting blood out, and now our lungs are impaired from poor gas exchange, that's going to decrease our oxygenation, which is just going to exacerbate the problem, because the little blood that we are getting out to the tissues is no longer oxygenated. So then you've got a double whammy there. This decreased cardiac output and decrease in oxygenation causes decreased cellular oxygen supply, which is the definition of shock, decreased tissue perfusion, and impaired cellular metabolism. Definition of shock. And if you notice here, this decreased cardiac output, remember, what's that first branch off the aorta? Thank you, coronary circulation. So if I have really bad cardiac output, that exacerbates my ventricular ischemia because I don't have any perfusion to those coronary arteries that I need to supply the pump. So then this just becomes like a snowball effect. Any questions about that? Okay. All right, so clinical manifestations. Keep in mind, the way your book is structured, they go into each specific type of shock, and then they talk about your compensatory phase all across the board when it comes to shock. So in cardiogenic shock, the early signs are going to look like kind of acute decompensated heart failure. What do you think your heart rate would be doing if you're not perfusing adequately? Tachycardia, because my sympathetic nervous system is activated. So that's heart rate greater than 100 beats per minute. What do you think my blood pressure is going to look like on the outside of my heart? Decreased, so hypotension. And then this is a key for cardiogenic shock. This is one of the hallmark signs. We have a narrowed pulse pressure. So you have the systolic and diastolic pressures getting closer and closer together. Basically, that number between systolic and diastolic, if you subtract diastolic from systolic, over time you'll see that that number is decreasing. That's what that narrowed pulse pressure means. So know that narrowed pulse pressure is associated with cardiogenic shock. Our cardiac output's going to decrease to less than 4 liters per minute. What about our cardiac index? What is that going to be less than? Yeah, very good. Less than 2.5 liters per minute per meter squared, and that's that cardiac output over body surface area. It's a more specific indicator of cardiac output for the individual, because how much my heart pumps is going to be a lot different than how much a larger person's heart's going to need to pump to perfuse the tissues. What do you think is going to be happening with their respiratory rate? If they're not oxygenating adequately, how do you think you would feel? Short of breath, anxious. So they're going to be tachypnic. They're going to breathe faster. Shortness of breath. What do you think their lung sounds are going to sound like? Crackles. From what? The fluid backing up, the pulmonary edema. Because that heart can't handle all the volume inside. So if there's a lot of volume inside of the heart, this is another hallmark of cardiogenic shock. What do you think the pressures inside of the heart are going to look like? High. Very good. So your PAWP and your CVP are going to be really high because the actual engine or the pump is back flooded. So all of this blood is engorging the ventricles. It's too high inside. Most other shocks, you're going to see those being low. But in cardiogenic shock, all that fluid's backing up and it's not being pushed forward, so it's just sitting there with that hydrostatic pressure just pushing against the ventricles. So we have an increase in PAWP and an increase in CVP. Especially if those ventricles are non-compliant, those pressures are going to be really high. We're also going to see an increase in systemic vascular resistance and pulmonary vascular resistance. What does that mean to you? Vascular resistance. How? Yeah, like it's how much pressure do I have to overcome to get inside the tissues? But if someone's really edematous, we talked about how it kind of looks like heart failure, pretty much, all the tissues are really high in hydrostatic pressure. So it's not going to be very easy to get that blood out to the tissues because there's so much hydrostatic pressure in the vascular bed that it's going to be really hard to get that blood out there. It's kind of like that example of trying to open a door with someone else pushing up against it. So the vascular resistance is going to be really high. What does that do to your cardiac workload? It's going to increase it and therefore increase your oxygen demand. But I'm already having a hard enough time perfusing, which leads to poor oxygenation in the pulmonary bed, so that oxygen's not getting in there. So then that causes even more problems. That would increase my cardiac workload. What do you think their pulses would feel like? From a weak heart, it's going to feel like a weak, thready pulse, right? So, weak, thready pulses. Now, what's happening with the kidneys? Am I getting good blood flow to the kidneys? No. So I have renal ischemia, which starts what system? RAS. Yeah, so RAS, which further expands what in my body? Volume, because RAS tells my kidneys reabsorb sodium and water, excrete potassium, vasoconstrict. Now my systemic vascular resistance is even higher, and my volume's even higher, over-engorging that heart again. So then increase volume and vasoconstriction. So my lab studies, you guys just went over these. We've got cardiac enzymes. This is caused by myocardial damage. Troponin level, we can do EKG, chest x-ray, echo. If we have systolic dysfunction, what is that echocardiogram going to tell me? Poor, thank you, ejection fraction. So if you have systolic dysfunction, my ejection fraction is going to be less than 60, less than 55. It's going to be hard to get that blood out. So let's move into hypovolemic shock, okay? So hypovolemic shock, pretty straightforward. Loss of volume. What could cause it? Bleeding, is that what somebody said? Yes. So hemorrhagic is a type of hypovolemic shock. In your book, it says, you might have an increase in H&H, but that's if you're losing volume without loss of red blood cells. If you're losing red blood cells, you're going to see a decrease in H&H. So it's going to depend on the cause. The lab values are going to be reflected based on the cause. So going back to test 1, if I'm hypovolemic because of diabetes insipidus, I'm insidiously pissing, I'm losing all that plasma volume, right? So that crowds my red blood cells together. Yeah, I would see an increase in H&H, an increase in sodium. But if I have hemorrhagic shock where I'm actively bleeding out, all my red blood cells are leaving too. So then my H&H would decrease as well. Does that make sense? So it's a loss of intravascular volume. Meaning the prime, the stuff inside the vessels. So I don't have enough volume to carry around those red blood cells and therefore the hemoglobin that I need to oxygenate. So some types of absolute loss would be hemorrhage. We could lose it from the GI tract with excessive diarrhea, excessive vomiting. We talked about diabetes insipidus because we need ADH to tell us not to pee too much, but if we don't have enough of that, then we just pee continuously. Diuresis on its own. What other disease process can cause polyuria? Diabetes mellitus, right? One of the 3 Ps. So if we have excessive diuresis from that, or if we have excessive diuresis from diuretics we're giving, so over-treatment with diuretics. We could also have relative loss of volume, where the fluid's still in the body, but it's just moving to the wrong spot, right? So if we have third spacing, you'll learn a lot about that on the next test for like liver failure. If we have third spacing from malnutrition, because what's that big protein in our vascular space? That albumin. You guys are sick of hearing that? So that has a really high oncotic pull that should stay inside the vessels. It should never be moving anywhere else because that lets you know the capillary membrane sucks or you're just not producing enough because you're malnourished. So third spacing from malnourishment, from liver failure. What else would cause fluid to move from the intravascular to the interstitial space? Burns, thank you. Yep, and then this kind of coincides with another type of shock. Sepsis does as well. So in sepsis, I would really encourage you guys, in order to understand the spectrum of SIRS, sepsis, septic shock, to review the concepts behind inflammation. And we did provide those handouts for you in the back. So I'll do like a brief overview of it when we talk about SIRS. But just make sure that you guys understand the concept of inflammation and what it does. Because if you can understand that concept, all you do is apply it to the different organ systems. So even in ARDS, you've got this inflammatory response overrun. In SIRS, you've got this inflammatory response that's systemic now. It's not just in one spot. And we're going to go into detail about that. But I can't emphasize enough how important it is to understand the basic concept behind inflammation, because then you just apply it to the system, apply it to the normal physiology, and you'll get it. So sepsis is where that inflammatory response is overrun. Your capillary permeability is too high, and fluid's moving out of the intravascular space. And then eventually albumin moves there too, and it pulls fluid with it. So if you can understand that, you can get the whole spectrum, which seems to be like one of the harder concepts to grasp, but you can do it. believe in you. In terms of the pathophysiology, you just don't have enough volume. So decreased intravascular volume leads to decreased venous return to the heart, which means decreased what? Stroke volume, preload, decreased preload. Remember, preload is the volume at the end of diastole. So decreased preload, and therefore, like you said, decreased stroke volume, decreased cardiac output, which means, definition of shock, decreased tissue perfusion, and impaired what? Cellular metabolism. What happens, what does that mean when they say impaired cellular metabolism? You're not in aerobic. So you are not able, you don't have enough oxygen to perform aerobic metabolism, which gives us a lot of ATP and doesn't have as many bad byproducts as anaerobic. What is a byproduct of anaerobic metabolism? Lactic acid, which is hydrogen ions. So then you become acidotic as well. So that's what they mean by impaired cellular metabolism. Your clinical manifestations of hypovolemic shock. What's my heart rate going to do to compensate? Tachycardia. Increased heart rate, increased respiratory rate. My stroke volume decreases, as well as my CVP and my PAWP. Do you see that this is decreased in hypovolemic shock as opposed to cardiogenic where it's increased? I can't emphasize that enough. So hypovolemic, you don't have enough preload. You don't have enough stroke volume, so your CVP and PAWP are decreased. You would see changes in your hemoglobin, your hematocrit, your electrolytes, lactate, ABGs, O2. It's all going to depend on what the cause of the hypovolemic shock is. Like I said, if it's hemorrhagic, your H&H is going to decrease. If it's something where you're losing excess volume without loss of red blood cells, that's going to increase your H&H. So just be aware of what the cause is. Questions on hypovolemic? So the next type of shock is neurogenic shock. You guys studied this a little bit in test 1. So the etiology is a spinal cord injury above T6. Above T6 makes you sick. That's what Miss B says. So you're susceptible to neurogenic shock with a spinal cord injury greater than T6. It could also occur with spinal anesthesia, like an epidural, or a drug overdose with opioids or benzodiazepines. So some of your benzodiazepines, Ativan, lorazepam, the Xanax, alprazolam, Valium. Okay, so look for those names in association with possibly a neurogenic shock. Your pathophysiology of neurogenic shock. So we have some sort of insult to the spine, which leads to a lack of sympathetic nervous system stimulation. When we talk about sympathetic nervous system, what hormones are we talking about? Epi and norepi. So epi is going to increase that heart rate. It's going to bronchodilate. It's going to cause, norepinephrine is going to cause vasoconstriction. So then if we have a lack of sympathetic nervous system stimulation, what happens to the diameter of our vessels? Opens, dilates, vasodilation. So we have massive vasodilation. What's going to happen to my heart rate? It's going to decrease. So bradycardia is the hallmark sign. This is the only type of shock where your heart rate's going to decrease, because the problem's with sympathetic nervous system stimulation. So then that's going to cause lack of innervation, which means decrease in your heart rate. The whole reason we can compensate in other types of shock is because we have a sympathetic nervous system that's saying, get that heart rate up, get that contractility up. But here in neurogenic shock, we basically have the pipes completely open, so we have no tone, we have no perfusion pressure, and also our heart is just kind of like, I don't even know what's going on. Just like beating so slowly, so less than 60 beats per minute. So our clinical manifestations. We have decreased blood pressure, hypotension. We have bradycardia, decreased heart rate, less than 60. So this is your hallmark right here. What's that term for temperature that goes according to the room temperature or whatever they're touching? Poikilothermia. I butchered that. That's poikilothermia. So you want to make sure your patient's adequately warmed because they're just going to take on whatever temperature that they're surrounded by, whether it's a solid object, whether it's the air. Let's look at the difference between neurogenic shock and anaphylactic shock. So with anaphylactic shock, we have our etiology. This is an immune response. This is one of those acquired immune responses. It's an exposure to an antigen that the patient has been sensitized to. So this is an immune-mediated response. Someone who has an allergy to peanuts, let's say it's mild at first. Well, every time they're exposed to peanuts, their body has more and more of a response. So they're at risk for potentially having an anaphylactic response in response to peanuts, even though they seemed like it was just, itching or something like that when it first started. The more and more you're exposed to this antigen, the more and more your immune system mounts a response to it. It can be, these types of antigens can be a drug, a chemical, a vaccine, a food, like we mentioned peanuts, insect venom, like in My Girl. Do you remember when Macaulay Culkin was allergic to bees? Anybody seen that? Yeah. So sad. So anaphylactic shock could be in response to any of those antigens. In terms of the pathophysiology, your chapter on immunity goes into really intense detail about this. Basically what happens is you have an antigen exposed to the patient, and then we have release of vasoactive mediators. So the vasoactive mediators, with regard to the immune system, the inflammatory response, that's going to vasodilate and cause an increase in capillary permeability. And you guys are going to get sick of hearing that because that's all we're going to talk about in SIRS and shock. We have increased capillary permeability. What does that mean? It's leaking, yeah. So my vessel normally has this, this certain amount of permeability, like kind of a net. But when we have these vasoactive mediators released, like prostaglandins, serotonin, leukotrienes, what happens is it makes it more permeable, meaning that water leaves, but what else leaves? Albumin. So albumin's going to leave too, as we have an increase in capillary permeability. Those big protein molecules that are supposed to only be there in the vascular space moves out with albumin, meaning even more water is going to follow it. So you see this like massive edema with patients in anaphylactic shock. So our fluid's moving into the interstitial space. And this is going to cause the greatest threat of death in what part of the body in anaphylactic shock? Airway. Thank you. See you back there. You're like, look at me. So we see this with laryngeal edema, where the airway is closing. So that would be our first priority when it comes to anaphylactic shock, is getting that airway open. That leads to bronchospasm as well, and respiratory distress. But we're also going to see all that fluid leaving the intravascular space, so we're not perfusing properly because the fluid's not in the right space. It's all moving outward. Questions about anaphylactic? All right, so I'm going to pause this. So septic shock you got it?
I don't know.
So one of the main causes of septic shock is going to be a bacterial infection that's moved to the blood. So we could also have it from parasites, fungi, and viruses. In terms of the pathophysiology, we have microbes that enter the body. This causes an increase in inflammation, as well as coagulation, because the inflammatory response doesn't just have to do with the diameter of the blood vessel. It doesn't just have to do with how permeable the capillary membrane is. It also has to do with platelet aggregation and fibrin deposition. So I'm going to leave this right here and kind of go into an inflammatory response review. I'll come back to this slide. So in terms of the inflammatory response, this is a sequential reaction to cell injury. It is non-specific. It is part of our innate immunity. So this is how we respond with every single insult that doesn't have to do with our acquired immunity, that doesn't have to do with those antigens, antibodies, lymphocytes. This has to do with getting a cut on your hand. This has to do with, it could even be caused by maternal problems like abruptio placentae, where it becomes systemic and then causes DIC. So this is a non-specific response to any type of insult or injury to the body. First, we have a vascular response. In terms of like a localized area, there's transient, meaning temporary vasoconstriction. Your endothelium releases something called thromboxane, which causes like a super vasoconstrictive response. But your endothelium also releases nitrous oxide, which causes vasodilation. So that endothelium you guys studied in the atherosclerosis chapters doesn't just line the inside of the vessel as a protective layer. It also releases substances. It's like borderline hormonal. So any insult to that endothelium, whether it's like mechanical, chemical, that can cause an inflammatory response and a response from the vessels. From there you have release of histamine and other chemicals by injured cells. And this is where the vasodilation predominates. You've got histamine, which increases vasodilation. It increases capillary permeability. Serotonin does the same thing and also causes smooth muscle contraction, which causes like vasospasm. The kinins, like bradykinin, stimulates smooth muscle contraction and contributes to the pain response, vasodilation. Your complement components, they tell cells where to go. So a lot of these chemical mediators are going to dictate to the white blood cells, this is where you go. Remember those, we'll talk about this with the cell-mediated response, but your neutrophils come first, and they're the site of an acute bacterial infection. That's why you see depletion when it comes to an acute bacterial infection, which is the shift to the left, because your neutrophils are the first line of defense in terms of white blood cells, and then your monocytes are going to come after that. But your complement components basically tell them where to go. They also help with cellular lysis, where they penetrate the membrane of the cells to destroy the invading cells. Prostaglandins cause vasodilation. Your leukotrienes cause chemotaxis, which is like chemical texting between cells, telling them where to go. Leukotrienes also have a lot to do with the airway and bronchospasm. And then the big ones that you'll hear about in SIRS are the cytokines. They tell cells where to go, what to become. Like we know monocytes, when they're in the tissues, become macrophages. So these cytokines are going to tell white blood cells, this is where you need to go, this is what you need to release, this is what you need to turn into, basically. So cytokines are going to be the ones that are dictating this response. And this is, I think it's chapter 11. If you guys wanted to, with all of your extra reading, I'm not sure if you have time, but we'll go over it in terms of the physiology as much as we can. It's chapter 11 in your MedSurg book if you need a refresher on inflammation. We talked about plasma proteins like albumin. What's that? Oh, okay. I thought the screen went away. Plasma proteins like albumin. So we have all these chemical mediators telling the vessel walls become more permeable. The plasma proteins move into the interstitial space. And when this is localized, when it has to do with an actual wound, it should be fairly contained. But imagine what happens all over your body if this is happening everywhere. So then you lose your vascular volume because it's all moving into the interstitial space. You don't have any oncotic pressure in your blood vessels. So this draws fluid from the intravascular space. And if it were localized and if it were normal physiology, that's so that it can dilute the invading pathogen so that those white blood cells can come and basically phagocytize or gobble them up. So that's the purpose of it, but in SIRS, it's overreactive so that you have a loss of the volume, you have a loss of your capillary membrane integrity. But remember I said it's not just vessel diameter, it's not just permeability, it's also blood clotting. So your liver produces something called fibrinogen, which is an inactivated or precursor form of fibrin. So fibrinogen converts to fibrin, which is that sticky spiderweb-like substance that pulls clots together. So then if this were localized, this would hopefully stop hemorrhaging. But if this is systemic and it's happening all over the body, you go into DIC. So fibrin strengthens that blood clot. Formed by platelets, which are those fragments of that cell that helps clot. The function of these clots is to trap bacteria and prevent their spread. And if this were localized, hopefully it would do that. You also have release of growth factors by platelets that help start the healing process so that your tissue can regenerate. But in DIC, we don't have time to grow any tissue. In terms of the cellular response, remember I said those neutrophils show up, so you see a change in white blood cell behavior. And we have monocytes, and they're going to show up to the site of injury. But in SIRS, that's everywhere. That's systemic. That's the biggest thing to take away from this, is that this whole thing is happening all over your body. And neutrophils and monocytes are going to be responsible for phagocytizing bacteria, for eating away dead cells. With the chemical mediators, we already kind of went over the functions of those guys. Got that complement system you guys learned about in microbiology that's going to tell cells where to go, destroy cells. They go into pretty extensive detail in chapter 11, but the big things you want to take away from it are the vasodilation, increased capillary permeability. And we have that clotting aspect of the inflammatory response. So that's just a peek inside inflammation. Let's move back to sepsis. So increased inflammation and coagulation after we have some sort of microbe that enters the body. We also have these microbes releasing endotoxins. We also have cytokine release. Remember, it tells those cells what to do, where to go, and other mediators. We have microemboli forming because of the clotting aspect of the inflammatory response in response to any insult or invasion in the body of a microbe. We talked about that the endothelium functions as an organ as well. So if we have these microemboli, we have damage to the endothelium, which leads to the release of those substances from the endothelium, causing vasodilation. And increased what? Capillary. So sick of it, aren't you? And then we also have neutrophil and platelet aggregation. And adhesion to the endothelium. So this is a type of distributive shock where your pipes are being completely destroyed and your vascular volume is leaving. So this is like a triple whammy, right? And you also have suppression of the myocardium with those endotoxins being released, and all those inflammatory mediators also cause that as well. So then your pump's screwed too. So pump, prime, and what's the other one? Pipes. So all three of them, triple whammy. When it comes to the sympathetic nervous system response, where does our body try to send blood? The brain, the heart, the vital organs. It shunts blood away from the GI, the GU, Nobody who's in septic shock, well, nobody who's like stressed out really feels like eating very much or having sex. That's kind of like that blood being shunted away from those non-vital organs from minute to minute. So those are non-essential functions in terms of second-to-second survival. So that blood's being shunted away from there. Remember, this is online, so I'm going to the next slide. So we have maldistribution of blood flow. That leads to tissue hypoxia and impaired cellular metabolism, poor perfusion. With septic shock, if we have this maldistribution of blood flow away from the GI, what do our bowel sounds sound like? Decreased, which puts us at risk for paralytic ileus, for peptic ulcers. So don't just think about what's happening with the heart, we think holistically. So we also need to get them on PPIs, get them on H2 receptor blockers to prevent that from happening. Because what happens if I have a paralytic ileus and nobody notices because they're rightfully concerned about all my other vital organs? Necrotic bowel. It turns into a perforation. What happens to sepsis after that if my bowel explodes? Super quadruple whammy. So paralytic ileus. Further sepsis. So that complicates the situation. You start to see systemic manifestations of poor perfusion and really any type of shock. So what does it look like for your brain not to be perfused? Change in LFC. That's the first and most reliable indicator of neurologic status. They may be agitated, they may be confused, they may have some sort of personality change or not understand what you're saying when they could a second ago. So you have to be hypervigilant about these things. When it comes to understanding shock, there are criteria, and this is the spectrum from SIRS to septic shock. So I'm going to draw it all in one slide. So SIRS, Systemic Inflammatory Response Syndrome. Your book defines it as a systemic inflammatory response to a variety of insults characterized by generalized inflammation in organs remote from the initial insult. So this could have started as a UTI, and now all of a sudden it's all over my body. So this inflammatory response that we talked about is everywhere. So in terms of your criteria for SIRS, it's two or more of the following. Number one, we could have a temperature less than 97 or greater than 100.9. So we could be hypothermic, we could be hyperthermic. We could have a fever. We could have a heart rate greater than 90 beats per minute. Notice that's not 100, it's just letting you know that your heart rate's increasing, right? A respiratory rate greater than 20 breaths per minute. We talked about the inflammatory response. What happens to your white blood cells? Yeah, we could have a white blood cell increase greater than 12,000 cells, or even less than 4,000, or a 10% greater than 10% bands. What is that called? Shift to the left. So your shift to the left is in your neutrophils. This is telling you that your bone marrow is shoving out premature or immature neutrophils, saying you're overwhelmed usually with this acute bacterial infection, so that your bone marrow is like, everybody go to the front lines, even if you're not ready. It's kind of like, I use this example all the time, like in Nazi Germany in World War II, how they started running out of people in the army because they were losing the war. And so they started recruiting younger individuals, older individuals, people who are not capable of being on the front line. So it's basically what's happening in your body when it comes to SIRS. So you have this shift to the left, meaning banded neutrophils, which are immature, are coming out instead of the segmented ones, which are mature. Remember we talked about poor perfusion to the brain. Another criteria for SIRS is altered level of consciousness or a mean arterial pressure less than 65. So 2 or more of these could indicate that your patient is in systemic inflammatory response syndrome. You can have SIRS without sepsis, but you can't have sepsis without SIRS. Have you guys heard that before? Yeah, so you're going to have SIRS if you have sepsis. You're going to have an inflammatory response if you're infected with some sort of bacteria or virus or parasite in your blood. And that's going to cause this inflammatory response all over the body, leading to sepsis. So sepsis, make it green like pus, because it's an infection. So sepsis is SIRS plus a confirmed infection. So whether it's a UTI, whether it's pneumonia, whether it's a wound culture, that's telling you that your patient has SIRS and a confirmed infection, which means sepsis. Now, septic shock is sepsis and what? Blood pressure less than 90 systolic in spite of adequate fluid resuscitation. How do I know that I've adequately resuscitated my patient fluid-wise? What hemodynamic monitoring do I look at? What kind of blood pressure where? CVP. CVP between 8 and 12. So if the volume I preload's adequate, but it's not getting out of my tissues, that's telling me my vascular system sucks because I'm overinflamed from an infection. So in spite of fluid resuscitation, my systemic blood pressure, even though I have enough preload, is not working. It's not coming out.
Don't you want these people at a CVP at 50?
You want it higher than normal. Yeah, higher than the normal levels. I think your book gives you 8 to 12. Like that you know you have enough preload.
Okay.
But that's telling you that if your CVP is adequately pressurized, that I have enough fluid in that compartment, well, once it leaves my heart, it's not, my pipes are shot, right? Because I have all this increased capillary permeability, vasodilation, microemboli. Does that make sense? Yeah. Make sure you do your reading. Bless you. So this is the spectrum from SIRS to septic shock. What is MODS? Yes. So MODS is multiple organ dysfunction syndrome. It is the failure, according to your book, the failure of more than one organ system in an acutely ill patient such that homeostasis cannot be maintained without intervention. So this MODS, according to your book, is a result from SIRS, Systemic Inflammatory Response Syndrome. So you want to catch this early because it could lead to